Dames en heren, beste collega's, van harte welkom op deze inmiddels alweer 17e Grand Round. Degenen die nog geen plaats hebben, die kunnen hier naar voren komen. Er zijn nog plaatsen hiervoor beschikbaar. Fijn dat u er allemaal bent. Zoals u weet hebben wij afwisselend een interne spreker en een externe spreker. En dit keer, dat weet u allen, hebben we een externe spreker. En die zal ik nu in het Engels aan u gaan introduceren. En heeft alles te maken natuurlijk met de introductie, de Big Bang op 27 oktober van Epic in ons eigen huis. And our special guest is Mike Pfeffer. Mike Pfeffer, his medical specialty is internal medicine. He works at University's Center of Los Angeles and is one of the biggest university medical centers in the world, I think. He is CIO, that's the Chief Information Officer of UCLA. And really a hotshot over there, and he was responsible for the implementation and introduction of Epic in UCLA. Almost 20,000 employees. Big introduction, even bigger than the introduction of Epic here in our University Medical Center. And he will explain to us about the pitfalls and all the important things to remember during this implementation phase. Mike, may I give you the floor for your grand round?
Great. Thank you, Jan. Goedemiddag, dames and heren. Thank you so much for having me here. It's really a pleasure. I really want to congratulate you on your upcoming go live. It's really an incredible thing to be putting in a new electronic health record. It really is a big culture change, and it can be difficult at times and complex and definitely anxiety provoking, but it's worth it. And why is it worth it? It's because it's good for the patients. We're really doing this for the patients. And as physicians, that's what we do. That's why we're here. We take care of patients. So I'm going to talk a little bit today about what really does make this better. So I saw you guys had something like this on your building before. So for those of you who don't know what this is, it's a tag cloud. And basically, it's a way to visualize words and their frequency. So the more frequent the word, the larger it is. And so in certain situations, the larger the word means it's more important. So I put this together really showing you what's really important, and hopefully it's going to help me tell you some stories as we go through this. So the first thing I want to really focus on is the patients, because really what we're doing here is putting in a patient-centered electronic health record. So at UCLA, prior to us putting in what we call Care Connect, our version of Epic, this is what we had. We had paper charts. And I kind of want to tell you a little story about what it was like for me in clinic. So I'm a hospitalist typically. I take care of patients in the hospital. But I also see patients in preoperative clinic. They come to me before they're going for surgery. I go over their medical care and get them ready for surgery. And often, all we would have are these charts. And if they saw multiple doctors, you can imagine what this quickly becomes. Multiple charts. And it's really hard to find the information you need. It's probably not going to be there if these charts live in different offices. So I was seeing a 70-year-old gentleman who was coming in to have his hip replaced. And I knew he had a history of coronary artery disease and renal insufficiency, and I wanted to get some more information about him because it's nice not to have to repeat tests. So I went digging. And so first I tried to find his EKG, and I found one, but it was 3 years old, so it wasn't very helpful for me. And then, well, I really would like to see what the orthopedic surgeon said. Are they going to have a total arthroplasty, a hemiarthroplasty? What kind of surgery? So I could maybe find the note. If you could read it, that would be great. And that's not really against any surgeons. My handwriting looks just as bad as that. And then, I'd really like to see his creatinine for his kidney function. And so maybe I can find some labs. Maybe they were done outside of our system. So really, I have to do a lot of digging. And because this gentleman actually had a really good exercise tolerance, I didn't have to do any more tests. He went to surgery for his total hip arthroplasty, and he did very well. But you can imagine that if you take this and expand it to multiple patients going through multiple venues, from hospitalization to rehabilitation to the pharmacies to specialties, it's very, very difficult to get all that information together. And it lives in silos in different locations. But what we really needed to do is come together into one and really put the information centered on the patient, not centered on the physicians or the place of care. So if you can put all this information together, what you really begin to do is tell the patient's life story. And that's really, really important. What we do when we write our notes, and each bit of our documentation really tells a story about the patient's medical life. And things like past medical history, surgical history, allergies, everything, how many children they have, all of that lives in the paper world. And what we want to do is really move that into the computer world, so it's accessible by everybody in real time. And so that is really one of the primary reasons for putting in a patient-centered medical record, as you are doing here. So after you put in this record, you really can take it to the next level with patient involvement. So my chart, we call that My UCLA Health, is how our patients begin to interact with the medical record. And as you can see, we had 21,000 patients sign up for our chart, for my chart, so they could access this from home. And just to give you some sense of that, that's about 21% of all unique patients that visited UCLA signed up. And so we're really working hard on this because we'd like to get this to at least 50% of our patients are using the record electronically. And so what can they do with this? Well, 9,800 messages have been exchanged since June between patients and our providers. And if you see, I showed a little breakdown on the bottom here. You can see that most of those are patient advice, so medical advice. But what I'd like to point out, which is really interesting, is the bottom one here, appointment cancellation. So we have a waiting list of months sometimes to see a specialist. And if a patient doesn't show up, we don't have time to fill in that gap. So another patient that could have been seen can't be seen. Why is that? Well, it's often very hard to cancel an appointment. You can't get through on the phones. It takes a lot of time. It's not that easy. But if you could do it from your iPhone or from your computer at home, that opens up another spot for a patient to be seen. So we're really excited about that feature that's in my chart. So that's a story about patients and why they're the most important thing about putting in the electronic health record. But let me talk a little bit about the electronic health record and a little bit about what we went through on our Go Live. So this is our press release. On March 2nd of this year, we took over 18,000 people at once at about 2:40 at night in the morning and put them live on a total enterprise version of Epic. We were supposed to go live at midnight, but 2:40 is close enough. We had a couple little glitches, but at 2:40 we turned on the system. And at that time we turned off all of our legacy products. So everybody in every clinic, in all our 3 hospitals, they were now using Care Connect, our version of Epic. So it was really, really exciting. This is a picture of our command center. Okay, it's really complicated. I still don't know where I was supposed to sit. Somewhere over in this area, I think. But I wasn't really sitting most of the time. So this is a picture of a part of our command center, and we're looking at the big board, as I like to call it. And on that board is where we saw all of our tickets coming in. So all the floor support, the super users, were calling in tickets, and we would watch this board. And we prioritized our tickets, just like you guys are doing, on a severity and impact score. So depending on if it affected patient care or if it affected many, many people, it got ranked from 0 to 5, 0 being the most critical, to 5, something we can do in a couple months. And luckily, we only had 2 what we call P0s, or most critical events, and I'd like to tell you about one of them. So that we turned the system on at 2:40 a.m., And the next night, I went home for about an hour and came back in. And we were told by our interface team that there were logs being generated in the interface engine. And these logs were important. They told us what was moving in and out of the system. And I know you guys have over 90 interfaces, probably more. We had about 90 interfaces, but I think you have more interfaces to other systems. And they told us that these logs were building up, and in 4 hours, our entire interface engine would shut down. No labs, nobody would get food because we interface with our dietary system. So this was a problem. And so we said to our interface team, why don't you go work on it? And myself, as well as our clinical leadership, sat down and began to figure out a plan. We were not going to turn off the system. So we had to figure out how we were going to care for patients if the interface engine went down. So to make a long story short, there's an application in the interface engine called the dump truck. And that is the technical name, the dump truck. And it's supposed to clear out these logs once they build up. And it wasn't working. But about 3 hours, 1 hour away from the interface engine shutting down, they figured out a way to kickstart the dump truck, and we were safe. The interface engine made it. So the moral of the story is you can pretty much fix everything that comes your way. Always have a backup plan, but we were really fortunate. We had a great interface team, and we were able to get things working. Most of the tickets that came in are like this cartoon here. So you can imagine two physicians, and what they're saying here is, they're okay, I guess. I just wish I could change the font. So really the point of this cartoon is to say that most of the things that are going to come in are really great ideas, and you can definitely change them later, but they're not critical. So a little bit about how we did. So I want to show you a little bit about our numbers. This is about 50 days after our go live. You'll get these, what we call key performance indicators that Epic will run for you as you go live. And some of the things we looked at were computer provider order entry. That's the CPOE. And we say provider because it's not just physicians. Nurses as well can enter orders in our system. You can see we hit 100%. So all of the orders in our system were being done in the computer. Very happy with that. Problem list was something that was very important to us. We wanted all our patients to have problems or their diagnoses put into the problem list. And we achieved over 90% on that. After visit summary, that's the document that you're going to give patients once they leave the hospital or the clinics. Something we did not do very well. We often had paper versions of that were hard to read. So this was a big improvement, and we hit 90% on that after 50 days. And finally, giving patient education material. So these are some of the things we were watching. We were also watching our rate of verbal orders. So these are orders given by physicians to other staff verbally, basically. And what you can see on the graph here, this is before we went live. And around this time here, before we went live, oh, these are sensitive screens. Before we went live, we kind of worked on this because we really wanted to reduce the number of verbal orders. Verbal orders can be dangerous because it's a communication issue between the physician and the nurse. But after our go live, you can see that the number of verbal orders continued to go down. And we average about 2% of our orders. We have about 60,000 orders a week that are generated on our system. And our verbal order rate is at 2%. So we watch that very closely, and we're very proud of that. So that's a little bit about the electronic health record. I want to tell you a little story now about providers. So you can see that the words physicians, nurses, medical students, residents, they're smaller in this tag cloud. And the reason I did that is because, what I've been saying is putting in this electronic health record is really about the patients. And if I redraw this 6 months after you guys go live, the physician words will become bigger because the system will be more kind of tweaked for the physicians. They'll become much more efficient, and they'll really begin to see the benefits. So I think at the beginning, you have to keep saying to yourself, this is really for the patients, but quickly you'll begin to, the physicians and the staff will really begin to see the power of this system. So Dr. Alice Chen is a colleague of mine, And she sent me this email a week after we went live. And I loved it. I saved it. So I'd like to read it to you. I would like to know whether I'm the first person to use Care Connect, which is our version of Epic, at 30,000 feet. I'm on a plane somewhere above Tennessee, signing notes, submitting bills, looking at overnight nurse assessments and vital sign updates, and feeling connected to the patients I left behind in California. Amazing. So she was actually on a plane. She was lucky to have Wi-Fi on the plane. Most of the planes in the US don't have it. But she was able to actually take care of her patients on the plane. And so that's really the power of this. I often get asked, what advice can I give physicians who are going through this? Well, here's a couple things. So again, it's all about the patients. Just remember that. That's why we're here. The residents, fellows, and medical students you have, they're geniuses when it comes to these systems. They just pick it up right away. So they were so instrumental in the adoption of Epic at UCLA. So they're wonderful. Make sure you go to them and you use them to help you through this system. In fact, we also used college students. We had college students volunteer to teach patients how to use MyChart. And that was really successful. MyChart is much easier than using Epic, which is good. So the patients don't have to go through 8 hours of classroom training, but it is a little complicated. And so we have volunteers work with them to help them get onto MyChart. Having a high availability help desk, so being able to call the help desk 24 hours a day, 7 days a week, that was really important for us. And constantly going through the help desk and seeing what people are calling about. I was in charge of sending emails to the physicians, and I really tried not to send many emails. So really relevant communication. So only when they needed to know something very important would I send an email out. Physician super users. So physicians who are super users for physicians was something we learned was really, really helpful, because you really want to have the same kind of people working with the users who are doing the same kind of role. And we talked a little bit about the command center. So we had a wonderful command center. It was staffed 24 hours a day for a couple weeks after our initial go live. And so we were able to troubleshoot and help people all throughout the night. Personalization lab. You guys do have a personalization lab. Ours is still actually open. We found it very successful. Physicians are still coming down to build their different phrases and macros and everything in the system. In-classroom training. So most of you, I think, are done with your training for this. So we did classroom training as well. And what we're also doing now is we're bringing people back. So after they've used the system now for about 6 months, we have a continuing education course, which I actually teach. And our next one is Thursday. If any of you are interested, you can come by. And we bring back the physicians and we let them do their work in the class. And we watch them and we give them tips and tricks. So rather than just lecturing to them for 3 hours and showing them this button and that button, we actually let them do their notes and work their in-basket. And then we can help them and say, hey, if you do this, it's going to be even better. And then finally, common sense. So the computer is not going to go over to the patient and listen to their heart. And we really had to drill that in. What we found is simply by turning on this system, people stopped talking. People stopped calling. And so we quickly said to everybody, continue to talk to people, continue to call. If you don't know how to do it in the computer system, take care of the patient. And this was really a good kind of mantra during our go live, to really, just use common sense. If you can't figure it out, deal with the patient first. So finally, I want to kind of tell a little story about the power of the electronic health records. It really has to do with improving health. And so what I'm going to do is show you a couple journal articles, literature, on how electronic health records are improving healthcare for patients. And it's not meant to be a comprehensive, and I'm not going to go into all the details about all these articles, but the point is, what I want to do is inspire you to be creative and think about what you'll be able to do in the system. What Epic allows you to do, what having a database of all your patient data allows you to do, is figure out how you can improve your patient's health, so your local population. Research studies, they're fantastic, randomized, controlled, double-blinded studies, but they're expensive, they're hard to do, and when patients are in the study, it's very regimented. So they take all their medicines, they go to every appointment, but that's not real life. So what this allows us to do is really look at how we are caring for patients locally and then make an intervention in our system here to improve patient care here. So the first article comes from the Annals of Internal Medicine, and it talks about colon cancer screening rates. And what they did was they tied the data in the electronic health record to colon cancer screening and used it to electronically mail out reminders to patients. And what they found was a 50% increase, so 2 times the number of patients were able to get colon cancer screening. So that's really fantastic. In this article here, C. diff, or Clostridium difficile infections in the United States is growing rapidly, and it's a big problem. But what if you could use the data in the system to say, for the patients who have this infection, who's going to relapse? The data's there. So you can have a prediction model in your system, and what they found was they were able to predict which patients, with pretty good accuracy, about 50% accuracy, which is really good, were going to have a relapse, so they could take care of them better. So in this article, readmissions is a huge problem. They looked at 30-day readmissions for cirrhotic patients, those with severe liver disease. And they said, how can we predict who's going to come back to the hospital? So again, they used a prediction model with data in the electronic health record, and they were able to basically predict two-thirds of the cirrhotic patients that were going to come back to the hospital. So a very, very good prediction model. And that allows them to provide care at home and better transitions of care to hopefully prevent patients from coming back. There's a really good article a couple years ago in the New England Journal of Medicine that showed that 20% of all Medicare patients in the United States are readmitted within 30 days. And what's disturbing about that, besides it's expensive, is that the patients that come back often come back worse. And they stay twice as long as they did when they originally came into the hospital. So by helping predict who's going to come back, we can work on making sure they have the proper care when they leave the hospital so they don't. So in this article from the Archives of Internal Medicine, they did a survey of hospitals that had electronic health records. And what they found was those hospitals that had notes in the system, clinical decision support, and order entry had fewer complications. So if you had electronic notes in your system, the study found that there was 15% less hospital-associated death. 15%. If you had clinical decision support, and again, these are broad, so the study has some limitations, but it was pretty eye-opening. Decision support lowered your risk of complications by about 15% as well. So these tools are available in the electronic health record and do make an improvement. It also showed lower costs as well. In this article, it talks a little bit about clinical decision support. So adult patients coming in after a trauma, and the question is, can we improve prophylaxis for venous thromboembolic disease? So DVTs, PEs. And what they found was by putting in a mandatory kind of guided evidence-based order set that allowed the clinicians to see that they needed to put the right prophylaxis on these patients. They had a 20% increase in the rate of prophylaxis in these trauma patients, and about an 80% decrease, so from 1% to 0.17% decrease in the rate of venous thromboembolic disease. So that's really incredible, just by putting in some decision support into the system. So shifting gears a little bit, this is a study that was done in Hopkins. And what they decided to do was put cost data right at the point of ordering. So and this was really geared towards residents. They had a group that didn't see this and a group that did. And they showed cost data when they ordered tests. And what they found was a 9% decrease in the number of tests ordered versus the control group, which had a 5% or 5 to 6% increase. So it's just something to think about. Providing this data in real time when you order things can really have an impact on the ordering habits of physicians. I often get asked about productivity. So you put in the electronic health record, it's difficult, productivity goes down. That is a true statement. So productivity goes down in the beginning. But how long does it take to get back, or does it ever get back? There's not many articles on this, but this one I like. This is from Cornell Medical Center. This is actually a number of years old. And what they found was that it takes about 6 months to get back to productivity. But after that, providers were seeing more patients than they were before. And they measured that in work RVUs. So work RVUs are basically a combination of the number of patients you see and their complexity. Higher complexity patient has more work RVUs. They had two groups in this study. What they called were adapters and non-adapters. So adapters did really well in the system, non-adapters not so well. But both of them made it back up to their baseline productivity after about 6 months to a year. And those that were really proficient did even better. So it's even more reason to really learn the system, come back after you've been on the system for a little while, and tweak what you know so you can improve your efficiency. So finally, this is one of my favorite articles from the New England Journal of Medicine. This comes out of Stanford. They've been on their medical record. They have Epic as well. They've been on it for, I think, 4 or 5 years now, maybe even more. So a 13-year-old girl with lupus came in very sick. She had pancreatitis, she had nephrotic range proteinuria, and she had antiphospholipid antibody syndrome. And so the question was, do we anticoagulate this girl? I'm not a pediatrician, but from what I understand, normally it's not standard of care to anticoagulate patients. But this patient was very sick. So what did they do to answer the question? Because there wasn't any literature. There's no studies telling you what to do here. So they mined their data. And one clinician in 4 hours was able to go into their medical record and find patients who had this similar situation. And what they found was that patients who were anticoagulated did better. They had less complications. So the risk of anticoagulating them was not as high as the risk of them getting a blood clot. So they did. And the authors wrote here, "We look forward to a future in which health information systems help physicians learn from every patient at every visit and close the feedback loop for clinical decision making in real time." And I think that's really powerful. And you're going to have these tools in a couple days. So I congratulate you on your upcoming go live. And thank you very much. It's been really wonderful being here and learning about your city. And I welcome any questions at this point. Thank you.
Thank you, Mike, for your great talk. It's a great honor to have you here. And,
Thank you.
I want to ask Lammy Elving to come. Lammy Elving is specialty is internal medicine as well.
Hi.
Head of the outpatient department of our internal medicine department. And Bart Koevoets, sitting here, manager of our lab.
Hi.
And they will ask the first questions.
Great.
To
Oh.
Shall I start?
Okay, Lammy.
Thank you for your inspiring conversation.
Thank you.
I think I speak on behalf of most of us that we are very excited that we are going to start with Epic.
Mm-hmm.
But we are all getting very nervous in the meantime. And this is not quite, it didn't disappear after your speech, let's say that.
Didn't.
So the first question I would like to ask you is, you told about this publication and it took about 6 months to get productivity back to what it was. And you started with the Epic in March?
Yes.
Yes, and that's about 6 months
Yes.
from now. So could you tell me about how your hospital is doing at this moment?
Absolutely. So that article really looked at outpatient setting. So in the hospital, we were completely full. In fact, we went live basically Friday night, Saturday morning, And Monday, we had the busiest OR day, or surgery day we've ever had, our anesthesiologists were telling us. So in terms of the hospital, we did not change at all. Our productivity remained the same. In the ambulatory clinics, so we started going live in our ambulatory clinics in June. So we have about 206 or so clinics that are going live in different ways. We have about half of them, or a little more than half of them, up now. And what we saw is by the end of 4 weeks, their schedules were back to normal. So they were able to see as many patients. However, they are spending more time on the system. So it really does take 6 months, and we're not quite there yet with our ambulatory practices to really get back to that level of efficiency. So you can ramp up your schedules within 4 weeks. I definitely recommend keeping the schedules low for the first 2 weeks, because it gives you an opportunity to learn the system. If you never learn the system, you're never going to get to that efficiency. So we dropped everybody's schedule by about half for 2 weeks. And then we ramped them back up. So they were back to normal at 4 weeks. By now, with our latest clinic go live, we were actually able to get the clinics back up in about a week and a half. So they were back to full schedule in a week and a half.
Okay. And what was the thing that you, that was the biggest problem then in the outpatient clinic? Because that's the thing that worries me most.
Yeah,
That we,
yeah.
Because when we were in class, then we had this lesson about EPIC and what we all had to do, and it took about a quarter of an hour, and then we would say, well, we didn't say anything to the patient yet. We just filled in all the things that needed to be filled in. So,
right. No, that's a great point. You know, I think the toughest, I think ambulatory is harder than inpatient for the reasons that you say. And I think the two hardest things about ambulatory, the first is the workflow changes for everybody. And really coming up with a new workflow from the front desk, the back office, physicians, and how the patients are going to flow is tricky. And that's going to be, I think, the beginning time when your clinics go live. Now, there is a benefit, and the benefit is it allows you to revisit your processes and really think, how can you make what you're doing more lean? And so it gives you an opportunity to kind of go through that with your staff. The second thing is spending more time with the computer than with the patient. What we have been trying to do, and when I spent a lot of time in the clinics, I would bring the patient in front of the computer with me, and we would do it together.
Share the screen.
And you know, it sounds kind of funny. Well, you know, I'm typing on the computer. This is my work. Why would the patient? But if you bring the patient in front of the computer and you show them what you're doing, and you show them their problem list and their medications, it's really a great bonding experience. Not only do you get your work done, okay, which is important,
but you're sitting side by side.
Side by side, looking at the computer. So obviously, there's a time where there shouldn't be a computer, where you're examining the patient. But when you actually have to put in your orders and you have to maybe update their history or whatever, bring the patient over. And then you're actually spending more time with the patient. And it's not easy to do, though. Okay, so I definitely, you know, it takes some practice, but that's definitely something you want to work on.
Is the patient advisory board satisfied with his answer? Or?
No.
I'm a bit worried because you said I like it to work together, patient and doctor, but you don't see the patients. You don't really see eye to eye with the patient. You're just typing. Patient can see what you are typing, but our concern is that the human touch disappears.
Yeah.
And how does it go with you at the moment?
So
do you really see the patient?
It's a risk.
It's a great question and a great concern. And I think the answer to your question, it depends. It depends on the provider. You know, the patient-physician interaction is unique for every physician and every patient. And some physicians really pick this up and understand how to focus the patient with the system. So they focus on the patient and they bring the patient into the system. And it can be quite powerful. And others aren't as good as that. And that is the truth. So it takes, it takes coaching. It takes feedback from patients to physicians if they're not spending enough time. But it certainly is an issue. What I will say is, when you first turn on the system doesn't have a lot of information in it. And so you are putting more information about the patients. But when the patients come back, when you come back for your second and your third visit, there'll be less time in the system because it's all in there. And they can actually begin to spend more time with you. And so it takes time. But it's definitely going to be a feedback. Feedback is necessary from the patients to the physicians.
You have to be open about that, I think, eh?
Definitely.
To the patients.
Definitely.
Okay, the second question will be asked by Bart. You know Bart from the golf course
Yes.
yesterday in
Yeah.
Groesbeek. We were playing a golf game, and we met Bart, who has a beautiful new club.
Yes, right,
Satisfied
yeah.
with that club?
I didn't play with you, but
No.
we met there. So
But there was
we
no
shake
time for
hands.
Epic, but there's now time for Epic. That's
Right.
your question, please. Right.
Right. Thank you. I'm business manager of laboratory medicine. That's a department and I just give a little background before
Sure.
I have my question, because I'm not sure the situation is the same in the US. Here we have most of the laboratory brought together in one department to optimize that process. And with Epic, we keep our own system, but we of course have interfaces with Epic.
Absolutely.
We do about 3 million lab tests and results a year with about 50 customers. So our biggest concern is about having the interface and having like
Sure.
you said, the processing got stuck.
Right.
Because then we need about more than 100 people to run around with
Right.
papers and everything, etc.
Right.
So my question is, what's your experience with the laboratory medicine? What are the biggest issues and how do you cope with them?
Sure. So we have a laboratory system called Meditech. That's our system, and it's heavily customized. And we had a fantastic laboratory team to help us integrate that with Epic, but it was certainly a challenge. In fact, I probably shouldn't tell you this, but I'll tell you anyway.
Well, please do.
So we turned on the system at 2:40 a.m., but the lab interface did not come up. And we decided to continue and just have the lab call in to the patients in the hospital the results. And about 2-3 hours later, we got the lab interface working. What I think is the biggest challenge for the lab is how the things are displayed in Epic. So it's different. It's different from what you're used to, the display of the lab tests, whether the microbiology is another concern, how it's displayed. So we spent a lot of time after the system went live diving into how we can make the display better. So the interface worked actually pretty well, a couple glitches here and there. Orders were passing through very nicely, but we wanted to make it visually better for the physicians so they could find what they needed a little better. So we actually just put in a really nice update to our results review tree with the microbiology. And specifically, the way it was when we went live was you would just see a box instead of an organism. So you didn't know if the culture was positive or negative. But we were able to figure out a way to actually display whether the culture was positive, negative, or pending, and if it was positive, what the organism was. So you could just scan along and see all the different organisms that the patient was growing. So I think just constantly revisiting and getting feedback from the physicians about how the results are displayed is going to be important.
We experienced that also with the testing, that
Yes.
the display is very important.
Right.
So you see the right thing and the complete information.
Right.
Are there anything, issues they say you really need to be aware to, because we have still a few days to go. Eh?
Right. Yeah, there's
can we-
nothing you can do now.
No?
I think, I think what's going to happen is you're going to get, this is very common, you're going to get a lot of people telling you a lot of things on day 1, 2, 3. But a lot of that changes after a few weeks. So we only really took care of the things that were clearly wrong. And the things that could be better, we waited. And we took all that feedback, and we really saw that what was said to us on the first few days was a lot different from what people were actually wanting in the end. They don't, you know. So, you know, we watched, we recorded everything, and then we sat down and we said, the microbiology, that's a real problem. And so we really dove into that and were able to fix that. So it's really kind of taking a step back and saying, you know, I understand that that is frustrating to you, but give it a week or two or three. And is it still frustrating, or is there something that's even worse that we can actually invest more of our time in? And that was really important for us.
Okay. Thank you.
Thanks.
Mike, you told us it's all about patients.
Yes.
And in Nijmegen, we have also the system that patients can see their own records and their own results. And the test results, we have a lag time of 1 or 2 weeks, depending the
Oh,
kind.
sure. Mm-hmm.
Do you have a lag time between the lab results, the test results, and the moment that the patient can see
Sure.
those results online?
So this was a big culture change for us. Before we went live, patients did not ever see their lab results. They had to go to the doctor, or the doctor had to mail it to them. When we went live, all normal lab tests, with the exception of a few that by law we couldn't release electronically. So all lab tests that were normal were released automatically to the patient in 1 business day. And then abnormal tests were released automatically after 3 business days, whether or not the physician saw it.
Even histology, for instance.
No, we did not. We're not releasing pathology or radiology. So it's basic laboratory testing at this point. And our plan is to release that information, but it was a real culture change for us to get those labs out in basically real time. And our goal is real time. So I want to do it so lab tests come out immediately.
And did it result until now into problems or communication problems, for instance?
Not really. I mean, you know, again, it depends on the patient and what the lab test is. The most sensitive lab tests we don't release automatically. They can be released electronically by the physician after discussing with the patient. But you can send a little note along with the lab test. And so the physicians have really been working on doing that. So if there's something abnormal, they would attach a little note onto the patient. So the patient, when they load it up in my chart, they can see it. You know, since the patients are able to communicate back through the system, you know, we have seen messages coming back and forth, probably a decrease in the amount of telephone calls and an increase in the amount of messages.
And who's answering the messages? The doctor?
Well, the messages go to the physicians have a pool, like a staff pool. Each clinic has their own staff pool, and they manage the initial triage of the messages.
As a team. Yeah.
Right, and then only anything that needs to get to the physician then gets forwarded to the physician, and they have the interaction.
Thank you. We have 2 microphones. Are there questions from the audience too? Okay. Please state your name and.
Jan Leer, and I'm head of the radiation oncology department.
Hi.
And well, you have radiation oncology as well in your hospital.
Yes.
Maybe you have answered already when you were discussing the theater program. There is a fear in our department when productivity goes down that waiting lists could increase. Is this something you have seen? And if this is not the case, at what expense is the productivity then goes down?
Right.
Science, education.
Right.
Yeah.
So we actually launched our radiation oncology. I should know this. My significant other is a radiation oncologist. That was our first clinic to go live on March 2nd. And our lead physician on our executive oversight board is the chair of our radiation oncology department, and has been absolutely fantastic in the process. So we did down schedule for them. They were able to get back up. Radiation oncology is a very complex department because you're interfacing. I don't know if you use Varian, ARIA.
Electa.
Okay. So it's very, very complex and unique from all the other clinics. So getting the interfaces between those systems to work is quite complex. On the flip side, your radiation oncology equipment, or the linear accelerators and everything, those aren't affected by EPIC. So those should be able to run at the same speed you're doing. So So it's really, going to affect your seeing the patients in the clinic, not so much your daily treatments. I don't have perfect data on, but they're doing really well now, and they've been a really fantastic partner
It's
in the
not
process.
so much that I'm afraid for the machines or for the treatment, but I'm afraid for the time that the number of patients we can see during the week.
Right. It does go down initially. The system, you have to learn the system. And radiation oncology, again, is a difficult one because you don't have another radiation oncology department, where with internal medicine, for example, we were able to shift patients to other clinics. So we had a shifting of patients depending on what clinic was going live.
Right.
So, so the answer is yes, there is going to be more waiting for a little while.
Okay, thank you.
Sure.
Okay. Other questions over there?
Hello, I'm Robert de Geer, pediatric urologist. If I understand well, you had a stepwise introduction of EPIC in your hospital. Well, we have a big bang with all the departments, all the outpatient, inpatient, emergency room, etc. Do you consider us to be wise or stupid to have that scenario?
So we had a big bang in all our hospitals. Our clinics got a view-only version of EPIC. So everybody was on the platform on day one. Scheduling, registration was live in the clinics on day one. So the whole front desk was live. The only thing that wasn't live in the clinics was order entry and documentation. So what our providers, a lot of our providers are asking to go live. So we have clinics that are not live yet on the full piece of it, and they want to go live because they feel like they're missing out. So I think a big bang approach is the way to do it. It kind of gets everybody on the same platform right away. You have less problems with different platforms and information not in the same place. I think overall your scope is smaller than ours in terms of number of people that are affected. But I do think the Big Bang approach actually worked really well for us.
Okay. Yeah, that's a question. Case?
Michiel van der
Sure.
Vlier,
Yeah.
Michiel van der Vlier, pediatrician. At the beginning of your talk, you mentioned there were still 2% verbal orders, and
Yes.
I wondered, are they in a specific department, or
Sure.
where doesn't it work?
Pediatrics.
So 2% for us is about right. I mean, there is a place for verbal orders in the system. If the physician is taking care of a patient, and that's critically ill or something happens and they need to order things, then we absolutely allow that. So our goal was to keep it at 2% and really identify providers that were 80%. So we know every single provider's verbal order rate. And the highest rate we saw initially was in the emergency room. And now we've had some interventions there, and that's considerably come down to about the same baseline, 2 to 3%. So that's where we saw our highest verbal order rates. I think OB/GYN was the next level. But there's nothing wrong with it. It's just we really wanted the physicians, residents, even medical students to enter the orders into the system because they can use our order sets, the decision support. If there's an alert for a medication interaction or a drug allergy interaction, they would see it. Where a verbal order, the nurse sees it, and the nurse has to be willing to talk to the doctor if they get an alert to work that out. So we really wanted to keep them low, but we're never going to be able to eliminate them, and that's okay.
Kees Tak?
Case attack, internal medicine, diabetes. My question is about correspondence. So most of us are used to dictate our letters to referring physicians and GPs, and now we're more or less shifting to putting together a document. What is your experience in terms of quality, first of all, and in terms of how much time that takes?
It's a great question. We did not turn off dictation, so our providers are allowed to dictate. We did that because this is a big enough change for us as it is, so we didn't want to, there's some things that I think are still worth dictating. You have really complex patients sometimes, it's easier to dictate. Templates work a lot of the times, but not all the time. So we have a hybrid system, basically. And then we have a very complex routing scheme to get those documents out to our primary care physicians. The way the system works is if the primary care physician is part of our network, then it goes right through Epic into their in-basket. Otherwise, it's automatically faxed out or mailed out if they don't have a fax number. It's not perfectly automatic, so if you type a document, you need to manually send it. We actually got it, so if you dictate a document and you dictate where it needs to go, it actually will go. So we have a hybrid system. As people get more familiar with the system and build their templates, and there's more information in the system that come into the templates, it actually becomes much faster to use the templates in the system, and dictation across the board goes down. That's what other Epic sites have seen. We're not really tracking that right now because we're not at the point yet where we really want to look at that and encourage people to move away from dictation. In terms of quality, that's really important. Copy forward, where you can take your note from last time, or someone else can take your note from last time and copy it forward and then edit it, is a big problem that we have. And what we're hoping is that because this system allows you to bring information from the patient into the chart using the smart links, that there'll be less copy forward. But that's something we're working on. Pretty much everybody in the US is working on it because it is a problem.
Okay. Thank you. There's time for one question, one last question. Yes, please. There's the microphone.
Hi, my name is Charda Tromp. I'm a research nurse for the Department of Surgery.
Great.
I would like to know if there was any way you pre-informed your patients, both out-clinic patients and in-clinic patients, before go live, about what was going to happen and what it would what way it would impact them.
It's a great question. So we mailed letters. We had signs up weeks before we went live in all of our clinics explaining what was going on. We had pamphlets, and we had volunteers and our patient services basically at all of our clinics, really working with the patients and helping them understand the transition we were going through. UCLA was one of the latest health systems to go live. So a couple of our neighbors in Los Angeles already were live on Epic. So a lot of the patients understood kind of what we were going through and the need to go to an electronic health record. So that was definitely an advantage for us. But definitely getting the signs up, not being afraid to talk about it with the patients. You know, we're learning a new system. It's going to be bumpy, but it's really for you, and in the end, it's going to benefit you is really important. I think full transparency is really the way to go.
Okay, sure. Thank you. Thank you, Mike, for your excellent grand round. It was great to have you here in Nijmegen, and we are really grateful that you want to share, or that you have shared your experiences with Epic. Thank you very much.
Great.
Dames en heren.
Thank you.
Thank you.
Appreciate it.
Dames en heren, er is nou tijd voor een cadeau.
Thank you.
De volgende Grand Round zal weer gehouden worden op de derde maandag van de maand, zoals altijd, in november. We hebben dan weer een interne spreker. Weer iemand die veel heeft betekend voor patiënten, net als heel veel mensen onder ons. Maar in dit geval ook wel een hele bijzondere, dus Emmanuel Milanus, die heel veel dove mensen blij heeft gemaakt met zijn cochleaire implanten. En hij zal vanuit zijn team de 18e Grand Round verzorgen. We zijn erg benieuwd naar en we hopen u alle daar weer te mogen begroeten. Voor nu tijd voor wat hamburgers en cola. And Mike will be present here for answering some questions. Thank you. Okay.